I request to Dr. Manoria, sir, please do start your presentation.
So we had very excellent presentation from all the three speakers. You are able to see my slides?
Yes, sir. Yes.
So in the next 5 to 7 minutes, I will try to demystify the nuances of DPI, which is a new concept in management of ASCVD. You have already heard that DPI means Aspirin plus Rivaroxaban dual pathway inhibitor. And this dual pathway, Aspirin provides antiplatelet action, Rivaroxaban inhibits thrombin generation, and also has an antiplatelet action. Now, the first big message which must percolate amongst all of us is when we are treating atherosclerotic cardiovascular disease, be it a coronary artery disease, be it a stroke or a peripheral artery disease, atherosclerosis should always be considered a systemic disease. So that if you're a patient of acute myocardial infarction, you must look at PAD and see cerebrovascular disease also. And roughly 16% of patients with symptomatic atherothrombotic disease has polyvascular disease, as you can see from this data of REACH registry, which means if you have a polyvascular disease, this immediately categorizes the patient into a very high risk group. So whether you are treating a stroke, whether you are treating PAD or CAD, you must look into the other two vascular territories, and if the disease is present, that has serious concern. The other thing you have to understand very clearly is that when you have suffered from acute myocardial infarction, even if you have undergone a very successful angioplasty, after 3 years, 20% of patients has experienced an event over 3 years. And what are these events? 40% will have MI, 18% will have stroke, and 40% cardiovascular death. So the question naturally arises, can we minimize this MI? Can we minimize this stroke in post-MI patient? And is the solution to this problem simple? Now, when we look at the two pathways of atherothrombosis, as you can see in the first year, it is platelet activation which predominates and is maximum at the onset of ACS. And therefore, DAPT in the initial stages and then escalation at the earliest time possible has become the standard of care. But as you can see, after 1 year, the thrombin generation keeps on increasing. And therefore, thrombin generation, which increase over time, inhibiting it will produce more and more benefit in the long run. So if you use an antithrombotic agent which decreases thrombin generation, the benefit is likely to increase over the years because more is the risk, more is the benefit. And you have to understand very clearly that thrombin generation plays more important role in stroke and PAD prevention and has little role in MI. Why I'm saying this? Because when we look at the data of COMPASS, what do you see? Cardiovascular death, MI, stroke, the primary endpoint decreased by 24%, highly significant. Cardiovascular death, again, 22% significant. Stroke, 42%, great benefit, significant. But look at MI, there is only a numerical decrease of 14%, which means that the COMPASS produces great benefit in stroke, great benefits in peripheral arterial disease, which I'll show you the data, but MI, there's a numerical decrease. This is the data on peripheral arterial disease. You can see that the risk of amputation is decreased by 70%. In our clinical experience, we have seen unbelievable benefit. Sometimes I'll present my case of patient coming up with threatening gangrene. After this strategy, everything has become normal. We are yet to do a CT angio again, but the clinical benefits has been immense and unbelievable. The patient was being taken for an amputation. The other thing you have to realize, because thrombin generation goes on increasing, and therefore if you put the patient on DPI for prevention of stroke and PAD, the benefit will also go on increasing. What is very interesting is that the bleeding risk over the years hardly changes because there is no precipitating, and therefore obviously if you follow these patients for a number of years, the benefit will go on increasing. And this is indeed very exciting because you will get a great net clinical benefit. Ischemic events increase, bleeding not increase is very interesting feature. And this slide was shown. You can see over the years, as you prolong therapy, the benefits keep on increasing. You can see stroke, which was here, stroke has increased, stroke reduction has further increased. The CV death also here, more increase and more increase, more benefit. But look at MI, some increase, which is a numerical increase. So keeping the duration of DPI in appropriate patients for longer period of time is going to produce more and more benefit without any significant increase in bleeding. And that is indeed the greatest achievement of the COMPASS trial. And this again was shown. If your patient has CAD plus PAD, this is a very suitable case. If your patient has CAD with stroke, the benefit will be maximum, and more are the risk factors, more will be the benefit. Now, if you look at the COMPASS data, previous stroke is only 3.8%, which means this is a strategy which is for primary prevention also and for secondary prevention also. So when you do not have any stroke, don't forget to utilize this strategy. It is both for primary prevention and secondary prevention also. So what do we get from all this? So when a patient of atherothrombosis, commonly ACS, presents to us, we know there are two pathways of activation. One is the platelets get activated and the thrombin generation increases. So what do we see? Platelet activation is maximum at the onset of ACS, then slightly cools down by the end of year, but also remains thereafter. But thrombin generation has a little effect in the first year, and therefore a DAPT is the standard of care for all patients of ACS in the initial period, and then we can de-escalate depending on the bleeding risk. But thrombin generation, look at this, an anticoagulant we prescribe for a short period in MI, but thrombin generation continues unabated, and we are targeting now with this new strategy, Aspirin plus Rivaroxaban. When you are treating this patient, you have to be very clear about the bleeding and the ischemic risk because both are very important. In past, we were making attempts to decrease ischemic events by more and more potent drugs. They are successful, but they are associated with increased bleeding. And now we know bleeding is associated with more morbidity and mortality than reduction in ischemic event. And therefore, currently, prevention of bleeding has emerged as a new focus in ACS care. And you can see many trials like Twilight trial and others. The primary endpoint is reduction in bleeding and not reduction in ischemic events. And currently, therefore, when we are treating this patient, we assess the ischemic risk, the bleeding risk. And as you can see, more is the ischemic risk, more mortality, more stent thrombosis, requires potent and longer drugs. More is the bleeding risk, increased mortality, less potent drugs, shorter duration. And therefore, all of us must be very, very familiar with this slide, factors which are associated with increased risk of bleeding, because many times this is not taken care of, and if bleeding occurs, this is associated with increased morbidity and mortality. So just to recapitulate, there are several scores, the Crusade scores and the BARC bleeding and so many. Even if you're not utilizing these scores, please be familiar with these factors, or you can put a slide in your cath lab so that you have a glimpse of. So aging, comorbidities, renal disease, very important. Increased bleeding and ischemic, liver disease, very important. Malignancy, very important, is a highly coagulant state. Anemia and low platelet count in the lab investigation. Stroke, particularly ICH and ABM. And if you have a bleeding diathesis, again, this is a very strong point. OAC with DAPT, triple therapy, you always try to avoid. NICD and steroids. and so on. And you can see here that if your patient is getting a PCI, post-discharge bleeding is more compared to a patient who is not getting a PCI. You can look at the hazard ratio after discharge. By 30 days, the hazard ratio is 19.3 PCI, whereas 15.9, and so on. Even at the end of year, the bleeding risk is more in PCI patient compared to a non-PCI patient. And therefore, our strategy at the present state of time, assess ischemic risk, assess bleeding risk, and try to land in this sweet spot so that you decrease the ischemic event, but do not produce any increase in bleeding. And that should be the approach, whether you are using antiplatelet agents or DPI or any other antithrombotic. So our attempt these days is, if you have a patient with CCS who has been on a single antiplatelet or an old MI who has completed DAPT, as already pointed out, if you have a high bleeding risk, look for this peripheral arterial disease, multivessel disease, CHF, CKD, diabetes, and recurrent. Even this amounts to prescription of DPI, because stroke, it offers great primary prevention benefit also. And then you can see if you have a stroke and PVD, there will be great benefits. If there is no stroke, the benefit is questionable. So the big message is, any patient of CCS or post-SEH, if he is a high risk for stroke, it means primary prevention, or he has already suffered from stroke or PVD, these are the patients which are universally accepted for DPI, and the benefits are great. The ischemic endpoints are decreased without any risk in the bleeding. If you have a CCS patient without previous MI, if there's no MI, again, the choice is DPI, DPI, and DPI. But the big question is, if you have a CCS patient with previous MI, DAPT seems to be the preferred approach, because I've shown you the decrease in MI in the COMPASS trial is only a numerical decrease. So our balance will tilt toward DPI in a post-MI patient, or if he has undergone an angioplasty, the high ischemic risk, multiple stents, bifurcation lesions, and left main lesion. So that should be remembered. But the big question is, because COMPASS trial has not shown a significant reduction in MI, is aspirin an appropriate option for antiplatelet arm for DPI? And the answer is perhaps not. So can clopidogrel be a more appropriate? Because we want to prevent our patients from MI as well as stroke. COMPASS prevents it from a stroke from a PAD, but does not prevent from MI in a significant way. And 40% have MI, as we said, 20% has stroke after 3 years. So can clopidogrel be a more appropriate option? People are trying to get a trial with this on the same strategy of aspirin plus Rivaroxaban. You should use clopidogrel plus Rivaroxaban, but a trial has not started. And this possibly seems a more appropriate combination, because we now have data from the host exam trial that if you use aspirin or clopidogrel in the long run, you have reduction in the primary endpoint, the ischemic benefits, you have reduction in the secondary endpoint. So you can see thrombotic composite outcome significantly decreased, cardiac death, non-fatal MI, ischemic stroke, readmission to ASIS or stent thrombosis. And as we said, bleeding is less with clopidogrel. As you can see, bleeding is more with aspirin. So perhaps in time to come, this trial will be initiated, clopidogrel plus Rivaroxaban, because aspirin is not preventing MI in a significant way. It is only providing benefit in the other two vascular strategies. And the other big question which is being raised is, can ticagrelor be an option for antiplatelet arm? There is an inclination for this, but no data is available. But this arm has also to be examined. This has already been examined in the Pegasus trial. This has also been examined in the other trials. So this is a very exciting option for futuristic trials, but certainly aspirin is not appropriate for reducing MI. So if you want to switch your patient who's on a DVapt to DPI, you have to take in mind that the antiplatelet agents like aspirin, clopidogrel, ticagrelor, prasugrel, they take time for the action to disappear. So a gap of 5 to 7 days for clopidogrel and prasugrel, because they are irreversible agent, 3 to 5 days for ticagrelor between DAPT and initiation of Rivaroxaban, I think all of us are very much aware. You cannot start from next day. The patient is on a DAPT, you start Rivaroxaban, and because this will be a triple therapy and may increase bleeding. The other thing is, if the patient is going for a surgery with a high bleeding risk, you can stop these agents 12 hours for the low dose and maybe 24 hours. But data from RFA and other procedures have shown that even if these patients are on anticoagulant, it doesn't increase ischemic or bleeding risk. Those patients have missed a dose, nothing to be done. You take the dose for the next period. Some of the contraindication we must be very familiar with. And the biggest contraindication is the patient has a high bleeding risk. The other contraindication is if there is some combination that you are using a triple therapy, then it is a problem. So bleeding, hypersensitivity is rare. Concomitant CAD, PAD, ASA, we've already discussed, but if the patient has a history of hemorrhagic stroke, you should not try to attempt DPI because hemorrhagic stroke is a strong factor for bleeding, and the bleeding occurs, ICH bleeding is very, pregnancy it is not recommended, and hepatic and other diseases we have already covered that they produce increased bleeding. So the other reasons we should be careful is if the patient has a severe kidney disease, EGFR less than 15, some bleeding disorders which are rare, severe systemic hypertension because they are bleeding in the eyes, they are bleeding at gastrointestinal disease with ulcers and bleeding tendencies, bronchiectasis with history of bleeding, and very important because Rivaroxaban interacts with CYP3A4 and it also acts with PGP. So there are drugs which interact with these agents, like the antifungal agent, like the verapamil, and some of the other agents. You should be careful and try to adjust the dose. So thank you very much for your kind attention.
Thank you, sir. Thank you for your presentation. We have few questions on board. For stroke prevention in chronic coronary syndrome patients, which one to prefer? Ticagrelor 60 mg or Rivaroxaban 2.5 mg? What do you say, sir?
See, we have said if there is a patient for stroke or PAD.
Anyone and any of the speakers can take up the questions.
If the patient has finished his DAPT and if there's stroke and peripheral arterial disease, DPI is the preferred strategy. If the patient does not have a predisposition for stroke, patient does not have a predisposition for PAD or is not having PAD, antiplatelet, isolated MI, no other vascular territories, DAPT is certainly the preferred strategy. But when there are disease in the other two strategies, unquestionably DPI is the treatment we must offer to the patient. If there are any comments from the other experts. Any other questions?
Yeah, so one person have asked for what duration Rivaroxaban need to be continued in chronic coronary syndrome patients. Can it be given if patient has only ischemic stroke?
The trial was followed for COMPASS trial for 3 to 4 years, so data is available for 3 to 4 years, but I have shown you the thrombin generation keeps on increasing for curious reasons. So the benefit may be more even after 3 to 4 years because thrombin generation is a reverse curve. Antiplatelet activity declines after ACS, thrombin generation goes on increasing.
Okay, sir.
Stroke, it is useful for the COMPASS has only 3.8% stroke patients, so very, very useful, 42% reduction in stroke. So stroke benefits are immense. And the benefits in PAD are also so. Primary prevention of stroke is a great achievement of COMPASS. Secondary prevention is also a great achievement. And reduction in the PAD, amputation, others are fascinating.
Okay. So also, is there any specific duration this Rivaroxaban 2.5 mg for the CCS patients? Specific duration that is there, or the patient has to consume is for a lifelong?
Lifelong data is not available. The data is available for 3 to 4
by
years.
your clinical experience, would you prescribe it for a lifelong, or depending on the patient's
completed few months? We don't know,
okay,
because their drug has been recently approved. So that is going to be explored. At the moment, the answer is not available. That it will be a lifelong therapy like statins and other drugs. The data is for 3 to 4 years. We have not yet completed 3 to 4 years. We will be seeing how it works in the long run. But one of my patients, the benefit is unbelievable. He was having threatening gangrene and he agreed for amputation because it was so painful. But when we put them, everything has disappeared. He is now moving about. That threatening gangrene has disappeared. In the CT angiography prior, his posterior tibial and anterior posterior tibial and anterior tibial were blocked totally. When he's coming for follow-up, we will repeat his CT angio to see what has happened to these, how this immense benefit was free. But the benefit was unconscionably great, and we never expected that he will come back for the next follow-up after 2 months with this great benefit. So we are very much excited. Sometime I'll present that case when he comes for follow-up. I'll repeat the CT angio and see what has happened to the arteries. But clinical benefit was immense.
okay.
Great, sir.
Thank you,
Any
sir.
other question?
Any other doctors who would like?
Any other question, Miss Anu?
No, that's all.
Now, there's one question in the chat box. Can you comment on trials of NOACs in ACS in sinus rhythm? I think NOACs were initially tried in ACS. We have the appraised trial with apexaban used in 5 mg twice daily, more bleeding. So the idea of using apexaban in ACS was given up totally. Then we have the REDEEM trial with dabigatran 50 mg, 75 mg, 110, 150 mg. Increased bleeding again, the idea was given up. And then we had the Atlas ACS to TB51, which showed great benefits, about 16% reduction in the ischemic endpoint, cardiovascular death, MI stroke, reduction in all-cause mortality, reduction in CV mortality, and laid the pathway for trying this patient in ischemic heart disease. And then we had this COMPASS trial. All other 2 NOACs have failed and people have given up with the idea of using NOACs in ACS. But Rivaroxaban was used in 2.5 mg and 5 mg. They utilize in the ACS in the full dosage. The apexaban was used in 5 mg BID. Dabigatran was tried in all 4 dosage, but the bleeding was immense. And but when Rivaroxaban was tried in 2.5 and 5 mg, it has shown reduction in ischemic events. The bleeding was increased, but fetal bleeding was not increased. So non-fetal bleeding in the Atlas ACS has shown increase, but the fetal bleeding, and that gave the thought that it should be tried in ACS also and in CCS also, and that led to the COMPASS trial. So only Rivaroxaban has data in the COMPASS trial. Rivaroxaban is unique. You don't have any data with the apexaban. You don't have any data with dabigatran. So that is the unique feature of Rivaroxaban. Why it has not produced increased bleeding like the other agent? One of the reasons was it was used in a lower dose, but dabigatran was also used in 50 mg. It produced, maybe that dabigatran is more effective anti-ischemic agent, and that's why it is producing more bleeding. So that is the summary of the NOACs trial in ACS in sinus. Then AF, we have many landmark trials.
Thank you so much, sir. Thank you for this wonderful session.